My dear students, in this lecture, I'm going to talk about the impact of nutrition in critically ill patients. We all know that nutrition carries a major impact on the course of the illness in a critically ill patient in the ICU, depending, of course, on the other comorbidities and the stage of illness and the duration of ICU, etc. But no doubt, it has a significant bearing on the entire duration of the stay and the subsequent problems faced by the patient in the form of infections, metabolic complications, all of which can lead to a prolonged ICU stay, a prolonged hospital stay, and as well increase in the morbidity and the mortality. So since this nutrition has an important bearing on whichever disease leads to the criticality of the patient, it is important to follow some pathways and get guided on the basis of some feedback mechanisms so that the salient features which influences these adopted pathways are not missed in the process. So let us begin with the case, a 72-year-old male, a known case of carcinoma tongue, post-radiation, post-operative, tracheostomized, is on mechanical ventilation. Patient is currently on volume control assist with an FiO2 of 40%, tidal volume of 8 mils per kg, respiratory rate of 20 per minute, I ratio of 1:2, and the displayed peak and plateau pressures seem to be normal. The patient is hemodynamically stable with mild tachycardia, almost near normal saturation on pulse oximetry, and a normal temperature. The ABG shows a pH of 7.45 with normal PCO2 and PO2, as well as normal bicarbonate. The lactate is normal. The patient is on currently at 120 mils per hour of IV fluids for maintenance, antibiotics, PPIs, analgesics, and supportive care. Now, the question that we need to answer is how long should we continue fluids and when it is good to start enteral nutrition or parenteral nutrition, as the case may be for this patient. So the first thing that determines understanding the nutritional needs is to the knowledge on how to calculate the nutritional needs. Now, to obtain the best calculations, it's always direct calorimetry, which is the best chosen or the suitable method for all patients. But this is not always possible, feasible, and available. Why so? Because in that patient has to be placed in an insulated room, and the change in temperature of the patient's body on because of the metabolic process should be absorbed by a known volume of water, and the temperature change in that known volume of water is used to calculate the total energy. However, the indirect calorimetry methods are not less accurate, and in many cases, they are used well to calculate the nutritional needs. In a mechanically ventilated patients, they rely on calculating the respiratory gas sampling, which is acquired by the circuit which is connected to the endotracheal tube or the tracheostomy tube to the ventilator, and is measured by a breath-to-breath or mixing chamber analysis. So what they aim is to determine the oxygen consumption and the carbon dioxide production. So since both oxygen consumption and carbon dioxide production is a function of the metabolic processes of the body, now they can be used to calculate the energy expenditure, which is also termed as resting energy expenditure. And there is an equation which is called the modified Weir's equation, WEIR'(S) Weir's. Initially, it was Weir's equation. Later on, it has been modified on certain parameters. So this Weir's equation gives a calculation of the resting energy expenditure. Now, in patients who are not mechanically ventilated but are spontaneously breathing, then a ventilated canopy hood or a fitted face mask is used to collect this inspired and expired gas. In canopy system, particularly, the patient's head is surrounded by a clear rigid hood and a pump pulls air through the canopy at the constant rate. So the basic idea is always to generate or gather the gas so that the sampling can be done and the VO2, which is the oxygen consumption, and the V star dot CO2, that is the oxygen carbon dioxide production, can be calculated. So in the absence of this technology, when neither direct or indirect calorimetry is available, weight-based equations are recommended. And that is one which is most commonly used in majority of the ICUs. Now, in weight-based calculations, we have to take into consideration certain patient factors to determine the calories and also the protein part. For calories, if the BMI is up to 29.9 kg per meter square, or rather up to 30, we give 25 to 30 kilocalories per kg. For BMIs between 30 to 50, 11 to 14 kilocalories per kg of actual body weight. And for BMIs of more than 50, 22 to 25 kilocalories per kg of ideal body weight. So in this case, you have to remember that these terms are, although they sometimes appear synonymous, ideal body weight, actual body weight, etc. So this is not exactly the same. And therefore, your actual body weight, the ideal body weight is measured by calculating the 1/3 of the actual body weight plus as determined by the scale, which is appropriate for the predictable body weight, which is determined for that age and sex. So predicted body weight plus 1/3 of the actual body weight gives the ideal body weight. So in this way, we will have to calculate the calories. Likewise, for proteins, for BMIs between 30 to 40, it is roughly 2 grams per kg of ideal body weight. And if the BMI is more than 40, it is 2.5 grams per ideal body weight. However, for all practical purposes, we have to remember that even if we forget this, the range for calculating calories should be 25 to 30 kilocalories per kg per day, with extra allowances if the patient is on ventilator, or and a protein requirement of 1.2 grams per kg per day. So always we have to see that recommendations are the starting point, and these recommendations should be adjusted based on the other medical conditions or treatments that can affect the energy requirement. And most importantly, if the patient is having comorbidities in the form of renal failure, where a lot of protein gets eliminated from the body, or patients with liver diseases where the protein synthesis itself is reduced, etc., so forth and so on. So recommendations are only the starting point and requires modification with time. Now, should we use any scoring system? And if so, which one? So no specific nutritional score that is exclusively validated for ICU use is there so far. But there are certain scores which has been found to be useful, particularly in prognosticating the patient, not only in the short term, but also for the long-term outcomes. So nutritional risk screening 2002 and MUST, that is the malnutrition universal screening tool, these have been found to have the strongest predictive value for mortality. And they are also the easiest scores and where calculation is also quickest. So although the other value, that is the nutritional risk assessment in critically ill, or the Nutric score, has also advocated, but when compared for determining the predictive value, the NRS 2002 and the MUST, they have been found to have the strongest predictive value. So in NRS 2002, that is nutritional risk screening, so if we can have a point system, the point 0 to 2 points suggests repeat screening weekly. And if the point is between 3 to 7, then it indicates that patient is at nutritional risk and there is a need for nutritional care plan, and that should be set up and followed. This nutritional status is classified as none, that is when the patient is not any risk, mild when the weight loss is more than 5% in 3 months, or 50 to 75% of the normal food intake in the last week, moderate when the weight loss is more than 5% in 2 months, or BMI is between 18.5 to 20.5 per square meter, and reduced general conditions, or food intake is reduced by 25 to 50% of the normal food intake during the last week. Severe, where the weight loss is more than 5% in 1 month or more than 15% in 3 months, or BMI is less than 18.5 kg per meter square and reduced general conditions, or 0 to 25% of the normal food intake in the last week. So this is mild, moderate, and severe. And the severity of the disease on the basis of stress metabolism is also indicated, either none, where there is no risk, mild, when in presence of hip fracture, chronic disease, particularly with complications like liver cirrhosis, COPD, diabetes, cancer, etc. Moderate risk in presence of stroke, hematological malignancies, severe pneumonia, extended abdominal surgery, etc. And severe when there is head trauma, then hematopoietic stem cells transplantation, Apache more than 10, etc. So that gives you the nutritional risk screening and gives the maximum number of points. In patients with advanced age, we get of more than 70 years is also considered as a risk factor. Now, in calculating, if we calculate the BMI score, there are 3 steps involved. The step 1, you calculate the BMI score, that is either if it is more than 20, it is 0. If it is less than 18.5, it is 2. And in between, it is 1. And unplanned weight loss in the past 3 to 6 months with a percentage score less than 5 is 0, more than 10 is 2, 5 to 10 being 1. And if patient is acutely ill and there has been or is likely to be no nutritional intake for more than 5 days, then the score is 2. So if we obtain the score and totally we determine. So every critically ill patient staying for more than 48 hours in the ICU should be considered as risk for malnutrition. So once we know the risk, how to fulfill the energy and the protein targets. So as I told before, it starts by determining the energy needs. If calorimetry is available, then we apply calorimetry. In critically ill mechanically ventilated patients, energy expenditure can be determined using indirect calorimetry. If indirect calorimetry is used, then isocaloric nutrition rather than hypocaloric nutrition can be progressively implemented after early phase of acute illness. If calorimetry is not available, then we can go for oxygen consumption from pulmonary artery catheter or carbon dioxide production derived from ventilator to give a better evaluation on the energy expenditure. If it is not available, then we go for predictive equations. If predictive equations are used to estimate the energy need, then we can give hypocaloric nutrition is preferred over isocaloric nutrition for the first ICU week of the ICU stay. Now, this is an important point that if we make calculations based on predictive equation, we would prefer hypocaloric rather than isocaloric. Whereas if we calculate the requirements on the basis of indirect calorimetry, we would prefer isocaloric over hypocaloric. Now, this is based upon 2 trials, the EPANIC trial and the EDEN trial, where they have both found that the weight-based, predicted body weight-based calculations slightly tend to overestimate the needs. And this has no bearing on the overall outcome, but they can lead to some complications short term. Whereas the direct calorimetry-based calculations have found that if isocaloric A has to be maintained, then the maximum effects can be obtained if it is started right from the beginning. So that is why this preferential difference of isocaloric versus hypocaloric feeding as determined by the measurement of on the basis of either direct calorimetry or predictive equations has come into foray. Now, after 3 days, caloric delivery can be increased up to 80 to 100% of the measured energy expenditure in case the patient has been started on hypocaloric nutrition. Also, it is known that in the early phase of acute illness, the body has good amount of energy stores which are activated irrespective of the fact whether the patient is put on enteral or parenteral nutrition or not, no nutrition at all. So if we tend to use, if we use hypocaloric nutrition, so that plus the energy which is already being the used by the body from the energy stores that make up the 100%. And if we try to give 100% of the calculated energy, then the percentage actually exceeds more than 100, which can have some harmful effect on the body. But subsequently, when the energy stores, the reserved energy stores are used up, there is not much of store left. So then that activation does not happen. And there, if we increase the energy requirements, that is more likely to have a positive effect. So this is the explanation for the difference. So if predictive equations are used, then hypocaloric nutrition up to 70% of the estimated needs is preferred over isocaloric nutrition in the early phase of acute illness. Next question arises is whether to start enteral or parenteral. And the answer obviously goes without saying that if there is any scope to start enteral, that is always preferred over parenteral. But if there is delayed medical nutrition, either enteral or parenteral, we have to also look for that there should not be any contraindications for enteral nutrition. So enteral nutrition should be, when enteral nutrition should be delayed, if the patient is on shock and shock is uncontrollable, hemodynamic and tissue perfusion goals are not reached, so then we have to delay enteral nutrition, or we can start low dose enteral nutrition when the shock is controlled with fluids, vasopressors, etc. In case of uncontrolled life-threatening hypoxemia, hypercapnia, or acidosis, so in those patients also, there can be some effects. It can be enteral nutrition should be delayed. In patients suffering for active upper GI bleeding, in patients with overt bowel ischemia, in patients with high output intestinal fistula, in patients with abdominal compartment syndrome, or in patients with gastric aspirate volume very high, that is not controllable. So in those cases, enteral nutrition should be delayed. Whereas low-dose enteral nutrition should be administered in patients receiving therapeutic hypothermia, and gradually it can be increased after rewarming starts. In patients with intra-abdominal hypertension without ACS, abdominal compartment syndrome, and in patients with acute liver failure, when acute, immediately life-threatening metabolic derangements are controlled and they're without any life support strategies. There are cases where parenteral nutrition should be started in patients of contraindications to oral or parenteral. It should be implemented, and this implementation should happen within 3 to 7 days. So parenteral nutrition should not be started until all reasonable strategies have been undertaken to improve enteral nutrition tolerance, and they have been attempted. In patients who have high risk for aspiration, post-pyloric, mainly jejunal feed can be performed. And also it is important that continuous rather than bolus enteral nutrition is tolerated better by the patients. And gastric access should be used as a standard approach to enteral nutrition. In patients when gastric feeding intolerance is not solved with the prokinetic agents, then also post-pyloric feeding should be used. So oral diet shall be preferred over enteral nutrition. Enteral nutrition is preferred over parenteral nutrition, but in any cases, if enteral nutrition is contraindicated, parenteral nutrition should start within 3 to 7 days. There are, between continuous or bolus enteral nutrition, the advantages, both have their own advantages and disadvantages, but continuous feeding method is found to improve tolerance, reduce the risk of aspiration, and there is provide increased time for nutrient absorption. But the problem is that feeding pump is required, so availability is an issue, and it may restrict ambulation sometimes, and it is, of course, more expensive. So continuous enteral nutrition is indicated in initiation of feeding in critically ill patients, where tolerance is the factor in order to promote tolerance. In patients with compromised gastric function, feeding into the small bowel, intolerance to other feeding methods, etc. The cyclic or the intermittent, cyclic and the intermittent, they are the other ways. Cyclic facilitates transition of support to oral diet, allows daytime ambulation, encourages patient to eat normal meals and snacks, whereas intermittent feeding method, where feeding pump is not required, in that cases, we give the feeding based upon the requirement of the patient. And the bolus, which is more physiological, feeding pump is not required at all. It is inexpensive and easy to administer. It limits the feeding time, and patient is free to move around, and more likely the patient will receive all of the formula. But again, there is some disadvantages of increased risk of aspiration, and hypertonic, high fat or high fiber formulas may delay gastric emptying, resulting in osmotic diarrhea. So bolus, continuous, cyclic, and intermittent. In out of that, continuous is probably the best, but it's sometimes difficult to implement, whereas bolus is probably the easiest to deal with in any patient who is tolerating and mobile, but it may has its own problems. And intermittent boluses can be a good option in which either of the two methods becomes difficult. So studies have found a significant reduction in diarrhea with continuous versus bolus administration. But besides this point, there is no other difference in outcome has been found equivocally across all studies. Some studies have found some outcome to be more, some studies have found some outcome to be less, but there has been no equivocal outcome common to all studies. So what rules should be followed before starting enteral nutrition? One, we should confirm the tube position, both clinically and radiologically. Secure the tube well so that it does not get dislodged. Sit the patient up to an angle of 30 degrees to minimize the risk of reflux and subsequent aspiration. Start feeding early, that is within 24 hours of admission or surgery, because this has been shown to reduce septic complications, length of stay in the ICU, and readmission rates in patients. Aspirate 4-hourly to ensure that the gastric residual volume is within the normal rate. Avoid bolus feeds, that is large volume of feeds in the stomach, which can increase the risk of aspiration. And use prokinetics if the patient is not tolerating enteral feed, and give them like metoclopramide 10 milligram IV TDS or erythromycin 250 milligram, etc. orally, etc. Now, which enteral feed to use? Hospital prepared feeds are much cheaper than commercially prepared feeds, but they can block tubes, and some recipes can give unpredictable levels of both macro and micronutrients. In addition, they may contain contaminated ingredients which are not sterile, so they must not be used for post-pyloric feeding or in patients with achlorohydria. Whereas polymeric preparations, which contain intact proteins, fats, and carbohydrates, which require digestion prior to absorption, in addition to electrolyte, trace elements, and fiber, tend to be lactose-free, as lactose intolerance is common in ICU patients, so they are preferred. Their preparations vary in their osmolality, calorie to nitrogen ratio, and carbohydrate to lipid ratio, and they can provide between 0.5 to 2 calories per ml, mostly although they provide around 1 kilocalories per ml. So polymeric preparations offer certain advantages which are not possessed by the hospital prepared feeds. Also, hospital prepared feeds are cheaper, much cheaper than the commercially prepared feeds. So the commonly used polymeric preparations include protein casein from milk, soy protein, maize and soya oils, and the carbohydrate maltodextrin. Which enteral feed to use? Elemental preparations. These preparations contain the macronutrients in a readily absorbable form, that is proteins as peptides or amino acids, lipids as MCTs, that is medium chain triglycerides, and carbohydrates as monosaccharides or disaccharides. They are expensive and only indicated for patients with severe malabsorption or pancreatic insufficiency. Disease-specific formula, they are usually polymeric and includes feeds which are designed for liver disease, maybe respiratory disease, renal disease, etc. So the ones which are specific for liver disease are low in sodium and altered amino acid content to reduce encephalopathy. Those who are specific for kidney diseases are low in phosphated potassium and give 2 kilocalories per ml to reduce the fluid intake. Those which are specific for respiratory disease are high in fat content to reduce the carbon dioxide production by reducing the carbohydrate. So what should be done in cases of feed intolerance? Now, gastric access should be used as the standard approach. Parenteral nutrition should not be started until all reasonable strategies to improve enteral nutrition and tolerance have been attempted. In patients with gastric feed intolerance not solved with prokinetic agents, post-pyloric feeding should be attempted. And in case of contraindications to oral and enteral nutrition, parenteral nutrition should be implemented within 3 to 7 days of admission into the ICU. Now, post-pyloric tube platelets placement requires expertise, is probably less physiologic compared to gastric and enteral nutrition, and could also be possibly harmful in cases of GI motility problems distal to the stomach. But the important thing is that they may reduce the risk of ventilator-associated pneumonia because the feed is already passing much below the stomach. So how should the nutrition continued after first 3 days? After first 3 days, the energy delivery, if calculated on the basis of predictive equations, can be gradually increased from less than 70 to up to 80 and almost up to 100% of the measured energy expenditure. The amount of glucose in parenteral nutrition or carbohydrates in enteral nutrition administered to the patients should not exceed 5 milligram per kg per minute, because this will ensure that the CO2 does not rise. During critical illness, 1.3 grams per kg of protein equivalents per day can be delivered progressively if the patient tolerates. And in this case, it is important to measure the urinary nitrogen. If the urinary nitrogen is increasing, then the protein has to be adequately compensated. If it is less, then we can continue with the same dose. The administration of intravenous lipid emulsions is also a part of the parenteral nutrition. For IV lipids, the upper recommendation is 1 gram per kg per body weight per day, up to a tolerance of 1.5 grams per kg per day. In excess, if you administer, it can lead to wastage or storage or even toxicity within the body. So this is discouraged. What are the other extra allowances which are required for resting energy expenditure? If the patient is having fever, then increase by 10% for each 1 degree centigrade above 37 degrees up to a maximum of 40 degrees. Beyond that, there is no requirement. Sepsis increase by 9% regardless of temperature. Surgery increase by 6% if the patient has had surgery or trauma. Burns increase by 100% if any size over 30%, or use the Toronto formula because that is available and can be calculated bedside. Protein around 1.5 grams per kg per day with a range of 1.2 to 2 grams per kg. Use 2 grams per kg per day if severe catabolic states exist, like severe sepsis, burns, trauma, etc. And all that cases provides up to 5.3 kilocalories per grams. In lipid provides 9 kilocalories per gram of lipids and should stolule, and it should be limited to 40% of the total calories that are coming should come from the lipids. Carbohydrates provide 3.75 kilocalories per gram in vivo, and we have to give the remaining energy in the form of carbohydrates. So it is the protein followed by the lipids, and the carbohydrate is the last ingredient among the nutrients which is used for the purpose of reaching the calculated energy. So a careful balance of macronutrients provides the energy requirements, while micronutrients are the vitamins and the minerals which are required by the patients. They are required in very small amounts to maintain health, but they are not required to provide energy. Now, if you look into some of the studies, the energy deficit and length of hospital stay can be reduced by one-step quality improvement in nutritional therapy, two-step quality improvement in nutritional therapy, and the intensive care unit dietitian can make the difference. So, in a mixed intensive care unit within a university hospital, using a two-step quality program, like bottom-up implementation of feeding guideline and additional presence of an intensive care unit dietitian, this has been found to be very effective. So this involvement of the dietitian is important. A bottom-up protocol improve nutritional support. The presence of intensive care dietitian provides significant additional progression. As you can see in these patients that there is a protocol. One is the baseline recording, then period B is baseline with protocol, and period C is protocol along with a dietitian. So all of these are related to early introduction and route of feeding, which achieves overall better and early energy balance. So oral nutrition during and after critical illness, spices for quality of care. So here, if you see that that this spices, it is as an acronym that there are it follows 5 themes, that is swallowing disorders, screening and management, patient global status overview, involvement of dietitians and nutritionists, clinical evaluation of nutritional intake and outcomes, and finally supplementation in macronutrients and micronutrients. So this is a part of the quality of care of all critically ill patients, and therefore this should be followed as much as possible. So if you see the different guidelines, the DGM, the SPEN or the ASPEN guidelines, there can see that some differences exist in the guidelines because the because the studies which have been done, they have found are diverse, and therefore on the basis of these studies, if we are making calculations, sometimes depending upon our inclusion and exclusion criteria, some studies get excluded, some studies get included, and so the ultimate outcome of analysis changes, outcome in terms of systematic review or meta-analysis changes. So as a result, when any guideline draws inferences, they are also prone to such change. Now, if you look into the micronutrients, both DGM and SPN says that patients should receive vitamins and trace elements if enteral nutrition cannot meet the daily needs, and if supplementary parenteral nutrition is required to ensure the desired calorie and protein according to the disease phase and the individual tolerance. Whereas SPN says that to enable substrate metabolism, micronutrients should be provided daily along with parenteral nutrition. ASPEN makes no such recommendation. With vitamin D also, DGEM makes that recommendation that patients may receive a pharmacotherapy with vitamin D when they have severe vitamin D deficiency. SPEN says that in critically ill patients with measured low plasma D3 levels or high dose of vitamin or with vitamin D of less than 12.5 nanograms per liter, then a high dose of vitamin D3 as a single dose can be administered within a week after administration. Aspen doesn't make any recommendations. Similarly, and regarding antioxidants or selenium, there is almost clear into that it is not approved by either the SPEN or the DGM, but a combination of antioxidant vitamins and trace elements in doses are reported to be safe in critically ill patients as per the ASPEN guideline, and they say that it can be provided to patients who require specialized nutrition therapy. But they do not make any recommendations regarding selenium, zinc, and antioxidant supplementation in sepsis because the studies results are inconclusive and conflicting. So some controversial exists within the guidelines, and one has to choose which is best as per the local protocol of the ICU and also for the patient. So tailoring these needs to the individual patient's needs of the nutritional therapy is based upon the principles that every ICU patient is at risk for malnutrition. Regular screening for malnutrition should be done. Close monitoring and frequent adaptation of nutrition is and should be encouraged. Early enteral nutrition is preferred. Micronutrients are mandatory if parenteral nutrition is necessary, but an individual adaptation to these changing needs is always necessary. So depending upon the presence of any renal system or the GI abnormalities, trauma, cardiovascular, respiratory, sepsis, or the same CNS in obesity, all these things can change, and it is important to consider the relevant points. For example, in obesity, it is very important for the diagnosis of malnutrition, because obesity is also a form of malnutrition. Substrate utilization, deranged metabolism are other important factors that are detrimental in obesity and needs to be considered at the time of institution of nutrition. In CNS, also a high risk for prolonged ICU stay and iatrogenic malnutrition, along with dysphagia and aspiration risk, plus frequent GI dysmotility should be considered as a significant deterrent. So likewise, other disease systems will also have bearing on the patient's needs, and the nutritional therapy needs to be tailored according to those requirements. So my final take-home message is that critically ill patients require rapid, effective, and complete nutritional support management. Nutrition in the critically ill, or particularly in patients in the ICU, is not as if one size fits all. So the need should be monitored, and for that reason, it is best to start the nutrition by a definite method, and then to adjust it after looking into all the aspects which may vary from patient to patient. A multimodal intervention for optimal nutrition therapy should be provided during critical illness, after ICU discharge, and following hospital discharge. So this continuity of care should be maintained. It should not be confined within the four walls of ICU, but also within the other locations of the hospital, and also at home once the patient is discharged from the hospital. So the entire spectrum should be followed, and that is why professional help is always required. The cornerstone of nutritional stewardship is the implementation of institutional guidelines. It is very important to develop institutional guidelines and to follow those institutional guidelines that should accord largely, if not wholly, with some of the major national or international standards, augmented by audit and feedback. This is very important because of the variability from patient to patient. Audit and feedback becomes all the more important. The quality use of medicine indicators, because indicators will give an objective method to assess our success or failure, and also the performance measures. So if the performance measures will determine that which appropriate method is appropriate for which group of patients and in which ICUs. So some kind of performance measures of all of these strategies should be compared and kept. So thank you